Okay, think back to maybe your first clinical shifts. You
Yeah.
see a kid who's tearful after a shot, right?
Hmm.
Or maybe a little one holding their arm really carefully after falling down.
Yeah, that feeling. You want to jump in and help.
Exactly. But maybe you felt, I don't know, a bit unsure exactly how to help with that pain.
It's a common feeling. And that's why we're diving deep today.
Right into understanding and, crucially, easing pain in children. It's such a core area for you as future nurses.
Absolutely. It's fundamental. Understanding pediatric pain goes way beyond just immediate comfort.
It's about that whole picture, isn't it? Comprehensive care.
And being a strong advocate,
Mm-hmm.
especially for kids who can't always tell you clearly what's wrong.
Yeah, precisely. So that's our goal for this deep dive. We've gone through some really solid material from Wong's Nursing Care of Infants and Children.
A key text, really foundational stuff.
Totally. And we want to pull out the most essential pieces for you on assessment, on management. Basically give you a solid base.
So you feel informed, feel confident as you keep learning.
Okay, so when we start thinking about pain in kids, what's like the number one principle?
The absolute bedrock, you could say, is believing the patient. Pain is whatever the experiencing person says it is,
Even if they're very young.
especially then. It sounds simple, but it's huge. Because younger kids, they might not have the words,
Right. They can't always articulate it clearly.
which leads straight into a really serious point from our readings.
The under recognition.
Yeah, and the undertreatment of pain in children. It happens more often than we'd like.
That's tough to hear, but so important to acknowledge.
It really is. It just underlines why our assessment has to be so careful and why we have to fundamentally trust what our patients are telling us or showing us.
Showing us, yeah. And remembering even the tiniest babies.
Oh, absolutely. Newborns feel pain. There's no question. Their nervous systems are definitely developed enough to perceive painful things.
That's such a critical reminder. We can't assume that just because they aren't talking, they aren't hurting.
Exactly. Now, the materials we looked at, they helpfully break down pain into different categories. Helps us understand it better.
Based on duration, how it presents, can you walk us through those?
Sure. So first up is acute pain. This is the kind that starts suddenly, usually doesn't last too long.
Okay, like after surgery.
Perfect example. Surgery, a broken bone, burns, even just procedures like getting blood drawn. It's directly tied to some kind of injury or illness.
Got it. Sharp onset, relatively short duration, linked to something specific. What's next?
Then we have chronic pain. This is the type that lingers.
How long is lingers?
Generally, we define it as pain lasting longer than the expected healing time, typically more than 3 months.
Okay. And what conditions might cause that in kids?
You see it with things like juvenile idiopathic arthritis, sickle cell disease, sometimes cancer-related pain that continues.
So it's less about a recent injury and more tied to an ongoing condition.
Precisely. It becomes part of their reality, unfortunately.
Right. Then there's recurrent pain. This sounds like it comes and goes.
That's exactly it. Recurrent pain means repeated episodes, often predictable ones.
Like what?
Think migraines, that recurring tummy ache some kids get, or limb pain that flares up periodically.
Okay, so acute, short, chronic, long, recurrent, comes and goes. And the last one was mixed pain.
Yes, mixed pain. This is where you've got a combination of different pain mechanisms happening at once.
How does that work?
Often it involves both nociceptive pain, that's pain from actual tissue damage,
Like a cut or a bruise.
right, and neuropathic pain, which comes from damage to the nerves themselves.
Ah, okay. So nerve pain plus tissue pain.
Exactly. You see this combination sometimes in cancer pain, maybe if a tumor is pressing on nerves, or with severe burns that damage both skin and nerve endings.
That framework is really useful for thinking about the different ways pain can manifest.
It helps categorize what you might be dealing with.
And our notes listed quite a few specific situations where nurses are likely to encounter pediatric pain. It's quite a range.
It really is.
Yeah.
You've got the everyday things like needle stick pain vaccinations, blood tests,
Yeah, brief, but definitely painful.
and postoperative pain, obviously. But then also conditions like headaches, migraines, tension headaches,
Abdominal pain comes up a lot too.
and musculoskeletal pain from injuries or other causes. Then there are neuropathic syndromes.
Like phantom limb pain.
Yes, for children with amputations.
Yeah.
And then the really significant pain from things like burns, sickle cell crises, and cancer itself.
Wow. It just shows how pervasive pain can be in pediatric care. So the big question, how do we figure out if a child is in pain, especially if they can't just tell us?
This is where your nursing assessment skills are absolutely critical. We look at two main things: physiological indicators and behavioral cues.
Okay, physiological things we can measure.
Right. Vital signs. Essentially, you might see an increased heart rate,
Hmm.
faster breathing, maybe higher blood pressure.
Oxygen saturation could drop too.
It could, yes. And another one, especially in babies, is palmar sweating, sweaty palms.
Okay, but those vital signs can change for other reasons too, right? Like fever or just being scared.
Absolutely. That's a crucial point. You never rely on physiological signs alone. They're just one piece of the puzzle.
Got it. So you combine that with behavioral cues.
Exactly. What is the child doing? How are they acting? This can be incredibly revealing.
Like crying.
Crying is a big one, of course,
Yeah.
but also changes in facial expression. Grimacing, frowning, squinting.
Body language too.
Definitely. Are they guarding a specific area? Are they really still and tense? Or maybe restless and irritable, thrashing around?
And it's fascinating how these behaviors change depending on the child's age. The notes gave some great examples.
They did, and those age-specific signs are things you really need to learn to recognize. For infants, besides crying, you look for those facial grimaces. Maybe they get really rigid or thrash their limbs.
Makes sense. What about toddlers once they start talking a bit?
Toddlers might use simple words, ow, boo-boo,
Yes.
hurt. They might also physically guard the area or pull away if you try to touch it.
You can almost picture that little one pointing and saying, ow. And
Preschoolers might get more clingy with parents. They might flat out refuse to move the part that hurts. And sometimes, yeah, they can seem quite dramatic in their reactions.
a bit of exaggeration maybe.
It can seem like it, but it's their way of making sure you understand something is wrong.
Right. Then school-age kids, they might try to tough it out more.
Sometimes, yes. They might try to be stoic, act brave. But you might see other signs, like muscle tension, or maybe they regress a bit, acting younger.
Interesting, like needing more comfort than usual.
Exactly. And finally, adolescents. They can usually talk about it, but
But there are still things to watch for.
for sure, they can generally describe the pain, well, location, intensity, type. But you might still observe muscle tension. Maybe they're trying to maintain control, minimize how much it's affecting them.
Okay, so we gather all these clues, the vitals, the behaviors, considering their age. How do we make it like a formal assessment? That's where the tools come in.
Precisely. We need systematic ways to assess and quantify pain, especially to track if our interventions are working. And the right tool depends heavily on the child's age and developmental level.
So for the little ones, the pre-verbal or non-verbal kids.
For them, we rely on behavioral scales. The FLACC scale is very common.
FLACC, that's an acronym.
Yes, it stands for face, legs, activity, cry, and consolability. Each category gets a score from 0 to 2.
So you observe the child and score each aspect to get a total pain score.
Exactly. There are others too, like CHIOX and NIPPS, the neonatal infant pain scale, specifically for newborns.
Okay, so observation and scoring for the nonverbal group. What about when kids can tell us how they feel?
Then we can move to self-report tools. The FACES scale, you might know it as the Wong-Baker FACES scale, is fantastic.
The one with the different cartoon faces.
That's the one. It shows expressions from smiling to crying. Kids as young as 3 can usually point to the face that shows how much hurt they have.
That seems really intuitive for them.
Yeah.
What about older kids?
Once they're around 8 years old or so, you can often use a numeric rating scale.
The 0 to 10 scale?
Yep. 0 is no pain. 10 is the worst pain imaginable. Most kids understand that concept by that age.
Familiar for adults too, which helps. The notes also mentioned a visual analog scale, or VAS.
Right, the VAS. It's typically a 10-centimeter line marked no pain at one end and worst possible pain at the other.
And the child marks the line.
Yeah, they make a mark where their pain falls.
Yeah.
But it requires more abstract thinking. Understanding that line represents a continuum. So it's generally better for older kids and adolescents.
Okay. And what if the pain isn't just a one-off thing, like after surgery, but it's chronic? Do we need different tools then?
Good question. Yes, for chronic or complex pain, we often need more detail. That's where multidimensional tools are helpful.
Like a pain diary.
Exactly. The child or parent tracks pain levels, what makes it better or worse, how it affects activities, maybe over several days or weeks.
Gives you a much bigger picture.
Definitely. There's also the adolescent pediatric pain tool, which looks at location, quality, intensity, a more comprehensive snapshot.
It's really important, though, that not every child fits neatly. What about kids with cognitive challenges or communication barriers?
Great point. We absolutely have to adapt. For these children, we rely even more heavily on those behavioral observations.
And input from people who know them best.
Crucial. Parents, caregivers, they often know the child's unique pain cues better than anyone. We might also need to use modified versions of scales or focus on changes from their usual behavior. It's about individualizing the assessment.
Okay, so we've done our assessment. We have an idea of the pain level. Now the relief part. The notes split this into non-drug and drug approaches. Let's start with non-pharmacologic.
Yes, these non-drug methods are incredibly important. They should be considered for all levels of pain, honestly. Great for mild to moderate pain on their own, and excellent alongside meds for more severe pain.
They help reduce anxiety too, right? Promote comfort.
Absolutely. And there are lots of options. Distraction is a huge one.
Like toys, music, video games.
Exactly. Anything engaging. For older kids, relaxation techniques, deep breathing exercises. You can even guide younger kids through simple breathing. Guided imagery works well too.
Helping them picture a calm, happy place.
And for infants, we have specific things like giving sucrose that sweet taste is analgesic for newborns during quick procedures like heel sticks.
Oh, interesting. I remember reading about that.
Swaddling provides comfort, security, and kangaroo care, that skin-to-skin contact with a parent, is incredibly powerful for comfort and pain relief.
So many good options there. And sometimes things like hypnosis or acupuncture might be used.
Yes, those are considered more complementary therapies, but can be effective in certain situations.
It's great to have that whole toolbox, but sometimes you just need medication. Let's talk pharmacologic management.
Right. When meds are needed, we think in categories again. Non-opioids, opioids, and adjuvants.
Okay, non-opioids first. That's like Tylenol and ibuprofen.
Exactly. Acetaminophen, Tylenol, and NSAIDs like ibuprofen or naproxen. These are the first line for mild to moderate pain.
Standard stuff, but dosage is key in kids, right?
Absolutely critical. Dosing is almost always weight-based milligrams per kilogram. You have to calculate carefully.
And you mentioned underdosing is a risk.
Yes, there can be a reluctance sometimes, maybe fear of side effects, but underdosing means inadequate pain relief, which we need to avoid.
Okay, so non-opioids for mild moderate. What about when the pain is more severe?
That's when we typically move to opioids. Morphine is often considered the gold standard for moderate to severe pediatric pain.
The standard against which others are compared.
Pretty much. But there are other options too, like hydromorphone, fentanyl, oxycodone. The choice depends on the situation, the child, how long we expect the pain to last.
Stronger meds, definitely needing close watch. What were those adjuvant ones again?
Adjuvant medications. These are drugs mainly used for other conditions, but they can help with certain types of pain, especially neuropathic pain, that nerve pain we talked about.
Okay, like what kind of drugs?
Certain antidepressants and anticonvulsants, for example, can be effective in calming down nerve-related pain signals.
Interesting. And how do we actually give these meds to kids? Lots of ways.
Yes, several routes. Oral is common if the child can take it. 4V intravenous gives faster relief, often used post-op or in emergencies.
Rectal, maybe, if they can't swallow?
Right, suppositories are an option. There are also topical creams or patches, like lidocaine patches, for localized pain.
And I've heard of PCA pumps for kids.
Yes, patient-controlled analgesia, usually for older children and adolescents, allows them to press a button to deliver a small dose of IV pain med themselves within safe preset limits. Gives them a sense of control.
That makes sense. Now, with all these medications, especially opioids, we have to think about side effects. The notes flagged some key ones.
Yes, managing side effects is a huge part of nursing care with pain management. Constipation is probably the most common one with opioids.
Right. What do we do about that?
Encourage fluids, increase dietary fiber if possible, and often proactively start stool softeners or laxatives. Don't wait for it to become a problem.
Good tip. Nausea and vomiting can happen too. Yeah.
Antiemetics, anti-nausea medications might be needed. Sometimes just changing the opioid can help.
Itching is another one. Pruritus.
Yes, particularly with morphine sometimes. Antihistamines might provide some relief.
And the really serious one with opioids, respiratory depression.
That's the one we monitor most closely. Slowed breathing. It's why regular checks of respiratory rate and oxygen saturation are absolutely essential.
And having the reversal agent ready.
Always. Naloxone needs to be readily available whenever opioids are being used, especially IV opioids. Safety first.
Definitely. Okay, so we've covered assessment, non-drug, and drug approaches, side effects. The notes also mentioned thinking about pain differently in specific groups of kids.
Right. Nuances are important. Infants, as we keep saying, show pain more subtly. You have to be a keen observer.
And children who are nonverbal or have cognitive impairments.
We rely so much on those behavioral cues, on caregiver reports. Their pain might look different, so careful assessment is key.
What about kids with chronic illnesses?
They might almost become desensitized to a certain level of pain, or their expression might be altered because pain is just always there for them. Again, individual assessment is vital.
It really hammers home that one-size-fits-all just doesn't work in pediatric pain.
Not at all.
And related to that is the idea of cultural sensitivity.
Hugely important.
Yeah.
Beliefs about pain, how much you should show it, whether it's okay to complain, what treatments are acceptable, these vary enormously across cultures.
Because we can't make assumptions.
Never. We need to ask, listen, respect their beliefs and practices. Use interpreters if there's a language barrier. Tailor the care to the individual child and family within their cultural context.
It's about providing culturally competent care.
Exactly.
Finally, the notes really emphasize the ethical side of this. Our responsibility.
Yes. Unrelieved pain is not just unpleasant, it's harmful.
Hmm.
It can have negative physiological and psychological consequences, short and long term.
So kids have a right to have their pain managed.
They absolutely have a right to effective pain control. And as nurses, we have a clear ethical and legal obligation to assess pain properly and intervene effectively. It's a core part of our job.
Wow, okay. We've covered a lot of ground. This has been incredibly helpful. If you had to boil it down to maybe 2 or 3 absolute key takeaways for nursing students listening.
Okay. First, assessment, assessment, assessment. Use the right tool for the child's age and development, believe their report, and observe carefully. That's number 1.
Got it. Assessment is foundational.
Second, remember the breadth of interventions. Don't just jump to medications. Think about those non-pharmacologic strategies, distraction, comfort measures, positioning. They are powerful tools.
Use the whole toolbox.
Exactly. And maybe third, always be vigilant about side effects and anticipate them, especially with opioids. Be prepared to manage them.
Assessment, broad interventions, and managing side effects. Great summary. This knowledge is just so vital as you all continue your nursing journey. It really empowers you to provide much better, more compassionate care.
Truly.
So here's something to think about as you move forward. We know our understanding of pediatric pain is constantly evolving. How might a deeper appreciation for the individual ways children experience and express pain, considering their age, condition, even their culture, change how you advocate for their comfort in your future practice?
That's a fantastic question to reflect on. How can you be the best possible advocate for that specific child in front of you?
Keep asking those questions, keep learning. You're going to make such a difference. Thanks so much for joining us for this deep dive.